Talk is about ACL deficiency and reconstruction, selected biomechanics by Jeff Hauk, spring 2019. Here we're going to look at laxity that's associated with ACL deficiency. Anterior laxity is best measured by the Lachman test and is the clinical standard. Rotational laxity can be measured by something called the pivot shift test, but it's difficult to perform and so is not really considered reliable clinically. The anterior drawer test, because it's done at 90 degrees and therefore recruits other ligaments like the MCL, it's no longer performed clinically. Here I have a video of a patient who, while instrumented, demonstrated his laxity to us. So this particular person had voluntary control of his laxity and then therefore was able to induce the subluxation on his own. So focus right here at the tibial plateau. And that's what excessive anterior laxity looks like. In the early 2000s, we performed many experiments looking at patients with ACL deficiency and how they compensate for the abnormal laxity that they're experiencing. This is a study that I performed on a step-down task. During the movement, which was just walking off of this step that you see here in the picture, the patient reported that they had subluxed. And so we were really interested in this data and were able to publish it in the Journal of Orthopedic and Sports Physical Therapy just as a case study. On the x-axis of this graph, we have the stance phase of gait, or the step-down task. And we can see about 20% here marks the same point that the picture is drawn, with foot flat and the knee about 30 to 40 degrees flexed. The y-axis on this particular scale is anterior displacement. The black lines are the trials that there was no subluxation. So we can see that the anterior displacement was less than 5 millimeters for the entire movement. But the subluxation trial, which is in circles, is clearly excessive in the anterior direction. And this was our key finding in this particular study. And so this is what a subluxation would look like. And these intermittent episodes of giving way, people think are associated with the development of knee OA and also poor muscular control. The other consequence can be cartilage damage. And so this data was taken from ACL deficient patients 24 to 14 years prior to testing. So some patients had lived with an ACL deficiency for quite a long time. And they were measuring essentially MRIs and using the MRI to model a cartilage strain before and after a hopping task. And so the hopping task was having the patients perform 60 single leg hops, a distance of 0.6 meters before and after they did the MRIs. And we can see here is the red is thicker than the dark blue, and then the green's kind of in between. And so this is the pre-activity thickness, and then this is the post-activity thickness. We can see that there's like a bigger kind of area here in yellow and red on the medial side. And there's some changes in color on more toward the green and a little less yellow here on the femoral side. And so they use this data to show that essentially there were particular areas in patients that had ACL deficient knees that had different strain in the cartilage, and i.e. thinner cartilage after their activity as compared to controls. And so this is one of the first measurements that really kind of helps us understand how cartilage might be behaving differently prior to getting knee OA. But what's well known is that a small subset of about 25% of patients with ACL deficiency can do extraordinary things like Thurman Thomas, who played for the Buffalo Bills without an ACL for several years. And so those people are called copers. So we compare copers to non-copers. Some things stand out. One thing is not laxity. Laxity is the same in copers and non-copers. But if we look at knee atrophy, atrophy is different in non-copers. And so this is hamstring girths measured by MRI, and we can see kind of the MRIs here to the left, and then here's kind of the circumference measurements on the right. And we can see this is the non-copers here as compared to the copers, which are hashed, and the quadriceps. Their hamstring muscles are all fine and fairly comparable, but the quadricep muscle and the non-copers is not fine, where the copers really are even from side to side. So why do patients choose surgery? It's clearly not to fix laxity or improve strength. 345 consecutive patients had really no difference in laxity overall when they were comparing copers to non-copers. And knee extensor strength was slightly different, but the association wasn't very strong. And when they correlated these same readings to things like ability to hop or self-report, the correlations were weak. And so clinically, if we're patient-centered, we really can't use these impairment-based variables to predict how our patients might come out clinically. So the primary reason for patients to get surgery is to stop giving way episodes and help them return to activity or return to sport if they're not a coper. So it's still open question, does surgery actually help the kinematics that are occurring? Does surgery, does the type of surgery matter? And does the risk of knee OA decrease? And is there better control with the muscles of the knee? And we don't really know the answers to the risk of OA and what type of surgery works better. So we're going to focus on kinematics and extensor control. So the first question, does reconstructive surgery improve knee kinematics? This is a fantastic study that was done recently using dynamic x-rays. So they have the x-ray recording rates high enough that they can take repeat x-rays as somebody's running. In this particular study, they looked at downhill running in 17 patients that had a single bundle ACL repair and compared them to 10 patients that had a double bundle ACL repair 13 to 14 months after their surgery. So at the first instant of contact is this picture here from the sagittal plane. And we can see that as the people have a slightly flexed knee at initial contact running downhill, and then shortly after that contact point, their knee extends. And so we could imagine the femur kind of rolling forward this way, and essentially the contact point then would shift posteriorly. And we also notice that the area of contact is much smaller on the tibia than the femur. And we look at it from the transverse plane, we see the same thing, only now we can see the contact areas on the medial and lateral condyle. So here we have the lateral condyle and the medial condyle, and we notice that essentially there's these contact pathways that the knee uses when it's running. And so essentially this study measured those pathways in ACL before and after reconstructive surgery in a single bundle and double bundle approach. And so by doing that, they were able to establish that both surgeries showed differences between surgical and the intact limb. However, anterior translation was controlled in both. So anterior translation was actually over-controlled in both. So surgery doesn't really restore normal kinematics, although it does help control anterior translation. So what about muscle control? So does the surgery or during rehab, what kinds of muscle control problems are occurring? And so this is an interesting study looking at squats and then early walking. They're kind of two different studies by the same researcher. And so essentially this is a small group of 11 ACL reconstructed patients, and which they noticed when people are doing squats, they took recordings of squats using 3D motion analysis, patients at 3 months and 5 months. And essentially the knee extension moment, so the amount that the loading that was going through the involved limb, or the ACL reconstructed side, was 38% lower than the non-reconstructed side. And it was only slightly better at 5 months. And so this is after a lot of rehab and aggressive physical therapy, as these young athletes would get. And still, in a bilateral task, they were not using the knee extension strength that they had available to them. And so that's interesting, because it's not a strength problem, it's a control problem. If we look at the compensation that they use to accomplish that, the moment at the hip and the knee during a squat is usually something around 1. So that means there's an even amount of hip moment and knee moment to go from low squat to a standing position. And at the 3-month time frame, the hip was higher than the knee, so it's a hip-knee moment ratio, by almost 2. So the hip extension moment was essentially compensating for the low knee extensor moment. And then at 5 months, it was only slightly better at 1.5. So again, the rehab wasn't apparently fixing this problem. Similarly, in walking, if you record 3D motion analysis of ACL deficient patients walking, we normally at foot flat will, of the gait cycle, we would see this posterior ground reaction force that would cause an external knee flexion moment. The response would be an internal knee extension moment, and this extension moment is decreased in patients with ACL reconstructed knees. And it's not that easy to see because it's symmetrical. So there's like a symmetrical decrease, but overall it's lower than normal. And so what this translates to is the normal knee extension moment's about 0.5 Newton meters per kilogram, or 50 Newton meters per 100 kilogram person. So here we see data from patients performing this single leg hopping task and running. And we see the curves here. So this is their knee extensor moment curves during the tasks. Here's the running trial in orange, and then the single leg hopping trial here in blue. And you can see that the loading is clearly higher for the running. And so note that the hop is about 2 to 3 Newton meters per kilogram versus running, which is 4 to 5 Newton meters per kilogram. But these data illustrated that in addition to the presence of deficits in the magnitude of knee loading, individuals following ACLR exhibit impairments in the dynamics of knee loading. So in essence, they were unable to match their opposite side. So here we have 6 to 9 months after ACL reconstruction, and we're looking at how patients are performing as they're being released to return to play. So essentially, these patients on average had a self-report score of 72.4. They had a hop distance, this LSI stands for Limb Symmetry Index. So it's a comparison of how far they can hop on the involved side versus the uninvolved side. And then they tested isokinetic strength. And this is a peak strength, and again, it's a limb symmetry index, so the involved to the uninvolved side. And then they did 3D hip and knee angles. And these are the tasks they tested, the hop tests. And so here we have a single hop for distance, and then you can time a triple hop, or you can also get the distance of the triple hop. And then you can do something called a crossover hop. So the crossover hop introduces, kind of out of plane trunk control and a little bit of twisting into the test. And so you can see here you have, they hop across the line and then across the line again, and you can measure distance and time. And so this is a good example here of a single leg hop, and they measured the 2 different parts of the cycle of this task. And so this is the propulsion cycle here, and then this is the landing phase. And so you can see I've drawn the ground reaction force in here, and we can see his trunk position. And so you would assume that in this case here that the hip and knee are either relatively equally loaded, or the hip might be slightly more. But if we look here at the landing phase, the trunk really is pretty far back at this instant in time. And so essentially the moment arm here that would go from the ground reaction force to the hip is much smaller than the knee distance. So you see this moment arm here. into the knee joint center. And so we would guess that the external load for the knee is much higher than the hip, and so that the quadricep force or knee extensor torque in this propulsion phase in this particular picture is higher. So that's kind of how you would look at this particular task. So what did they find? They found that essentially the self-report was 72% of normal, hop distance was about 80%, and isokinetic strength was still only 75% of the uninvolved side. So this really leaves us in a quandary when we think about return to play criteria. So we've seen data on a squat where clinicians were unable to understand the difference between the involved and uninvolved side, and that strength wasn't related to the compensations that the patient was using at the hip. And we also saw asymmetries in running as compared to a single leg hop. That was not that easy to detect, again, without 3D motion analysis equipment. So at a clinical level, the return to play criteria still focuses on some of these tests that we're now calling into question. And that includes limb symmetry during knee extension strength, the hop tests and symmetry during those tests, even though we know that they're much less demanding than something like running. And then self-report scores, like the KOS is the knee outcome scale, and global rating. And this study on the right was just performed this month, and we can see that basically it's a systematic review that selects these kind of 4 high-level studies that look at if the return to play criteria influences re-injury. Essentially, and this is a close-up of the criteria itself, and we'll kind of focus our attention here on the right-hand side because these are the passing thresholds for the different criteria, and we can see quadriceps limb symmetry index, hop tests, now a timed running test, whether they completed rehabilitation, so that's one set of criteria. Another, here we see the quadriceps index again, which is similar to the limb symmetry index, and then a hop test, a different self-report or patient-reported outcome, global rating, and again, isokinetic strength testing, hop tests, global rating, and knee outcome score. And so essentially this different criteria are what's used to guide return to play. And what seems to be obvious is that the data we just saw using 3D motion analysis is revealing that this testing doesn't really detect some of the asymmetries that patients are presenting with. And at the same time, we also know that in this particular article, they're going to say that the current return to play criteria isn't that effective at determining who's subject to return to injury or will experience a second injury. But it probably does an adequate job of helping us understand if the patients are at a level where they're going to be able to return to play and perform effectively. So what you should come away with is that new data is changing how we think about ACLR, and that you should expect changes in the current protocols to emerge. And the focus will likely be on clinical tests to determine compensations. So right now we really aren't detecting these compensations, or else we would be doing more about it clinically. And you should expect clinicians to be exploring ways to either understand the compensations or try techniques to try to prevent them. And the research focus will probably be on retraining normal, where they have higher knee extensor loads on the involved side, and what the motor control issues that are underlying it, because it's pretty clear right now that what's driving these compensations isn't an issue of strength, but it's some kind of motor control feedback loop, like perceived effort versus actual force output. And then also psychological factors could come into play. So in short, the story is still incomplete. Will probably unravel in your first few years as a clinician.